This thing is in the way here. Smooth it. Okay. Well, thank you so much. It's a pleasure to be here. Thank you for attending this conference. I'm going to speak a few words on the advances in MRI-guided radiation therapy for lung cancer. There's not a lot of data, but I think there are some exciting trials that are ongoing to use this technology for that purpose. More disclosures. So I'm going to briefly talk about what is MRI-guided radiation, how is it different from standard radiation therapy, how do we use it for thoracic tumors. So this is a nice, I think, introduction of the technological advances in our field in terms of the use of, for example, image guidance. Adaptive radiation therapy actually started in 1997 before these other technologies have started. The actual first MRI system, which we had at UCLA, was in about 2016. It was using a cobalt system, and the MRI-Iinac came about in 2012 with the V-Ray system and eventually the Unity Elekta system in 2018. And these are the two systems that are most commonly used in Europe and North America with MRI-guided radiation therapy. They're similar except that they use different magnetic strength. The linear accelerator portions are pretty similar. I'm more familiar with the Meridian system, which has been around longer. It uses a low field, 0.35 Tesla magnet, has a 6 megavoltage FFF mode, and double stacked MLC for IMRT. But there are actually other systems that are in development. So as I mentioned, there's the V-Ray system and the Elekta system, but there's a Canadian system that's being developed called Aura IT. They use a parallel orientation with a magnet to the linear accelerators, but the strength of the magnet is also similarly low, 0.5 Tesla. In Australia, they're developing their own system with a 1 Tesla system with 6 megavoltage linear accelerator. So this is a broad kind of conceptual view of why MRI-guided radiation may be helpful for some cases. First of all, I think the soft tissue enhancement imaging is better for a lot of our tumor segmentation, defining OARs for setup accuracy, and then it also allows us to monitor treatment response well with just anatomical changes, but eventually functional changes. With that, with functional changes, we hope that we're able to detect areas of response, maybe adapt the radiation based on treatment response, and reduce doses to areas that don't need as much treatment. And finally, the actual real-time imaging, I think, is very important that we have real-time assessment of the tumor so we can monitor motion, mitigate motion effects, but while also shrinking the margin when we deliver the radiation therapy. So in our field, there's various ways we are using image guidance, very much from implanting fiducial markers, using CyberNav tracking. As I know there are a number of units in Taiwan, but the Meridian and the MR-Iinac system allows us to be able to visualize the target in real time. You can see here in the bottom to be able to track not just the surrogate, but the tumor during treatment. These are a couple of pancreatic lesions that are being tracked during radiation therapy. I like to show this slide just to illustrate, like when you don't see what you're treating, I think it does put us at a disadvantage. You wouldn't get on the helicopter with someone who's blind, of course, blinded. Michael Jordan isn't as good if he's not opening his eyes when you shoot. Actually, there's the statistics. The number of free throws that one can make blindfolded, it's only 16. But with their eyes open, it's like 16,000. The power of seeing is incredible. So if we can't see what we're treating, what does radiation therapy do? What do we typically do? We use larger margins so we ensure that we don't miss the target. We limit our prescription dose to make sure that the target and OARs are safely treated, but that also is compromising our ability to control the tumor with non-ablative doses for things like that. So MRI-guided radiation has several advantages, as I said. It improves our ability to see the target, minimize margins. We could adapt the radiation based on interfractional changes between treatments. We can also continuously monitor treatment in the case of a tumor that moves significantly. This actually was treated on the Unity when I was at MD Anderson. This was just illustrate sort of the ability to see a right upper lobe tumor that we treated for oligometastatic consolidation. And as you can see on the bottom, the number of publications with MRI-guided treatment has increased significantly in the last 5 to 10 years. But moving on to more thoracic indications. So again, it's pretty early on in the field. So this, so when would we consider it to be advantageous? So as we know, for centrally located or ultracentral tumors, there's been a couple studies that showed that SBRT could be effective. However, recent studies have shown potentially it could be unsafe and damaging if you're treating ultracentral tumor with large margins or high doses to OARs, up to the fact that there's 15% lethal toxicity for this trial from Europe that use sort of less advanced treatment techniques to treat ultracentral tumors with SBRT. And we know that tumors are not all created equal. So this is the early studies we did with the MRI-guided treatment showing that comparing to 4D CT and doing the MR simulation the same day, we can detect differences in tumor motion, detect differences during treatment of how much it moved and how accurate we are doing treatment. So this was a comparison of 4D CT compared to imaging and simulation on the low field MRI, and these are 5 patients, just to demonstrate that, for example, patient number 2, between 4D CT and the same day within 30 minutes, the amount of the ITV delineation was very different because the patient, the tumor motion was different, the tumor envelope. And on the bottom is 5 of the 4 fractions. Again, patient 1 and 3, this is craniocaudal extent of the tumor motion was different day to day. So I think we can't really rely on necessarily 4D CT to always give us the best picture for how much the tumor moves. Regarding margins, I know we typically put on a set margin for treatment, and then we hope that that margin is sufficient. It's not overly treating our field. But let's think about why we do that. A surgeon would necessarily dictate how much margin they resect on when they go in, right? They resect how much it is necessary to remove the tumor completely. I think so. The paradigm shift here is that when we deal with better imaging, more real-time imaging, we could determine how much margin we radiate based on how close the OAR is and where the tumor is at that moment in time. This is kind of our typical workflow for adaptive radiotherapy with MR-Iinac. A patient is simulated on pre-hand. On the day of treatment, they come in, we put them on the couch, we re-sim them basically, we recontour all the organs at risk, the target, and then we display whether or not the original treatment plan would be sufficient to cover the target, spare the OARs. If the answer is no, we would generate a new plan called adaptive replanning, reevaluate that, and if it's acceptable to the goals of our treatment, the OAR tolerance, we would treat with adaptive plan. So again, going back to ultracentral central tumors, there was early experience from North America in Washington University. This was a 5-patient experience with ultracentral tumors treated to 50 gray and 5 fractions, where they assessed whether or not adaptive radiation therapy was needed. So in this study, they showed that up to 10 treatments out of 25 fractions needed to be adapted because the dose had exceeded the OAR targets for the bronchus, esophagus, such that if you adapted the treatment, you would be safer using this treatment approach. 30% of the time, there's better PTV coverage as the other reasons why adaptive radiation was used. This is the experience from Europe. The Europeans looked at 50 patients with 54 tumors, all considered high risk, either central, ultracentral, or prior radiation therapy was delivered, so reirradiation, or patients with interstitial lung disease were considered. So they all got ablative doses of BED greater than 100 with the fractionation listed. They achieved excellent local regional control, very few recurrences, and more importantly, they didn't see any grade 4 or 5 toxicity. So it appears that potentially we can treat more high-risk patients with this technology in certain situations. Other ways that I think we can use this technology is treatment of patients that we otherwise wouldn't consider for radiotherapy. This actually was a case series of 3, 2 at MD Anderson, 1 at City Hope, where we combined our experience with both MRI-Iinac technologies to treat cardiac metastases. We showed that we can deliver ablative doses using this approach. Allows us to dose escalate. The patient tolerated well. Tumor control rates were excellent. Furthermore, there are also experiences using this for peripheral tumors for single fraction. So this was, again, a European experience with single fraction SBRT using MRI guidance of doses between 28 to 34 gray, showing, again, good clinical outcomes with low morbidity in terms of chest wall pain from this treatment. There are many ongoing studies looking at how we can use MRI-guided SBRT for improving our outcomes. These are just a list of the studies that as of probably 6 months ago, and there's probably more studies on the way. It's still relatively early technology, and as we know, for early technological adoption, it's very difficult. In fact, some of the technology has gone through some financial hardships. But that being said, I think there is a momentum to use something like MRI-guided treatment for thoracic and upper abdominal radiotherapy, particularly with SBRT. Here are a couple of videos from our City Hope experience. We opened our program about 1.5 years ago. This was a patient with lower lobe lung tumor that had previous radiation that we used this treatment to minimize the amount of incidental radiation to the healthy lung and GI structures. We use a deep breath hold inspiratory technique, and the beam is only on when the patient is holding the breath. As you can see, that when the beam is on, you can see that beam being lit up. I know this is not a upper thoracic case, but this is a young man in his 40s who had synchronous 2 liver lesions, liver-only disease. The latest iteration for this technology allows us to track more than 1 target. So here we're treating 2 liver lesions, 1 at the dome, 1 below the heart, with simultaneously delivering a 10 gray per fraction over 50 of gray in 5 fractions. He actually had a complete response after this treatment. So in summary, MRI guidance is a different approach to the way we typically think about radiotherapy. I think combining imaging, motion management, and adaptive replanning allows us to use this for more complex cases, but it requires sort of new ways of thinking about how our role, radiation oncologists, in delivering treatment. We need to be more involved in the daily adaptive radiation planning. Here are a couple cases just to illustrate. This is actually my colleagues. Oh, this is actually my patient, sorry. This is an 88-year-old Asian Japanese man who had an exon 19 deletion mutation, adenocarcinoma of the lung. He had a prior pancreas cancer 8 years ago that was disease-free. PET scan showed a 2-centimeter isolated primary. He was referred for SBRT, but because it was near GI structures, stomach, and large bowel, we felt that it would be safer to use MR-guided SABR for this. This is the delineation of the target. As you can see on the right side, the stomach and the colon are outlined. This is dose distribution showing the 100% isodose volume and hotspots away from the organs at risk. And we're able to better spare the chest wall, bowel, stomach using smaller margins and breath hold technique. Second case, this was actually my colleague's case, 67-year-old man with metastatic thymoma with a very large primary, painful. He decided to use this technology because daily there were changes in the pleural effusion, so he felt that with daily adaptive treatment we can allow for better targeting of this target tumor without having to re-simulate the patient or miss the target with radiation. Here's the plan, fraction 1 and 2, just to illustrate there are some differences in pleural effusion, and on this situation we only adapt if there's significant changes in target coverage. It's more about target coverage than any sparing of OARs for this use case. So that's all I have. I'm going to pass this to Dr. Lin to talk about proton therapy. Any questions?
Questions for Dr. Lee? Any of you guys have used MR-Iinac?
Yeah. Oh, hey.
In Taiwan,
Yeah.
In Kaohsiung Medical Center, they have the first one, 0.35 Tesla in Kaohsiung about 3 or 4 years ago.
Yeah.
And in Taipei, in our hospital, Tri-Service Joint Hospital, we have Unity 2 years ago.
Okay.
Yeah, so in Taiwan, we have 2 MR-Iinac now.
Are you at the one at do you have experience with Unity?
Oh, yes.
Okay.
About 1 year. And we use for the lung cancer and the brain mets and the pancreatic cancer and the prostate cancer also. And for short course rectal cancer, total neoadjuvant therapy.
I see. Do you do only SBRT or do you do also long fractionations?
Oh, no, only for SBRT.
I see. Okay.
Yeah, because of the treatment time is quite long.
Yeah. That's great. Great. Thank you.
Any other comments or questions?
Okay. Dr. Lin?